Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 259 of our pharmacotherapy series, which majors in sexually transmitted diseases. The first question reads, GNB is a 31-year-old woman with a recent history of diffuse vaginal discharge and irritation. A wet mount examination of vaginal secretions revealed numerous trichomonads. Examination confirms the presence of an increased, yellow-green vaginal discharge. What subjective and objective clinical data support a diagnosis of trichomoniasis? Trichomoniasis is the most prevalent nonviral STD caused by the protozoan Trichomonas vaginalis. The overall prevalence is estimated at 3.1%, with the highest prevalence among African Americans at 13.3%. Trichomoniasis in women is asymptomatic or with minimal symptoms about 70% to 85% of the time. In men, Trichomonas vaginalis presumably infects the urethra, although the site of infection, urethra versus prostate, is uncertain. Classic symptoms of trichomoniasis in women include a diffuse, yellow-green discharge with pruritus, dysuria, and a strawberry, cervix, cervical microhemorrhages. The latter are typically seen only in 2% to 25% of cases. In almost all cases of trichomoniasis, a vaginal pH greater than 5 is observed. The Papanicolaou smear is associated with a 48.4% error in diagnosis when used alone. Direct microscopic observation of trichomoniasis using a wet mount is inexpensive and yields a high specificity, but it has a low sensitivity. Other testing options include culturing, rapid antigen tests, and nucleic acid amplification tests. The next question reads, how should GNB's trichomoniasis be treated? The only class of drugs that is effective for the treatment of trichomoniasis is the nitroimidazoles. In the United States, metronidazole and tinidazole are the only available nitroimidazoles and both are CDC-recommended first-line agents given as a single 2 grams oral dose. In addition, sexual partners should be simultaneously treated to prevent reinfection. Metronidazole cure rates are reported to be 84% to 98%, whereas tinidazole cure rates are reported to be 92% to 100%. Concurrently treating sexual partners might increase these rates. Tinidazole offers other advantages, such as higher serum and genitourinary levels, a longer half-life, and fewer gastrointestinal adverse reactions. Approximately 4% to 10% of Trichomonas vaginalis isolates exhibit a low-level resistance to metronidazole therapy and 1% to tinidazole therapy. However, higher-level resistance appears to be rare. If metronidazole 2 grams orally for 1 dose fails and reinfection is excluded, metronidazole 500 or 400 mg orally twice daily for 7 days can be used. However, if this regimen fails, either metronidazole or tinidazole 2 grams orally as a single dose for 7 days should be used. In the case of allergy to nitroimidazole compounds, patients should be desensitized to metronidazole and subsequently treated. The next question reads, GNB was treated with metronidazole 2 grams as a single dose. However, while attending a party, GNB experienced a severe headache, followed by nausea, sweating, and dizziness. Could GNB's symptoms be caused by metronidazole? Minor side effects associated with metronidazole therapy include nausea, vomiting, especially with single-dose therapy, headache, skin rashes, and alcohol intolerance. The alcohol intolerance may be attributable to a metronidazole-induced inhibition of aldehyde dehydrogenase, which results in the buildup of high serum acetaldehyde levels, although the true risk of this interaction has been debated. According to the manufacturer, patients should be warned about the possibility of nausea, vomiting, flushing, and respiratory distress after alcohol consumption, although reliable evidence is lacking. As a general rule, patients should avoid alcohol ingestion during treatment and for 72 hours after metronidazole or tinidazole therapy. In those patients who cannot otherwise tolerate oral metronidazole or tinidazole, a combination of intravaginal meconazole and metronidazole may be an effective alternative. The next question reads, SGR, a 31-year-old woman, is in her first trimester of pregnancy and has a history of recurrent trichomoniasis. She now complains of a diffuse, yellow vaginal discharge. The preliminary diagnosis of trichomoniasis is confirmed by a wet mount examination of vaginal secretions revealing numerous trichomonads. SGR has read much in the lay press on metronidazole and is concerned about her own safety as well as that of her fetus. Can metronidazole be used for SGR? During pregnancy, trichomoniasis is associated with premature rupture of the membranes, preterm delivery, and low birth weight. In one study, rates of preterm delivery appeared to increase in women who received metronidazole, but a definitive causation could not be determined. However, caution should still be exercised if metronidazole must be administered within the first trimester. Metronidazole is mutagenic in facultative bacteria and contains a nitroreductase enzyme. Long-term, high-dose metronidazole in laboratory mice is associated with the development of pulmonary and hepatic tumors. Midline facial defects have been documented in humans, but 2 literature reviews indicate that metronidazole is not a teratogen. In contrast, the use of metronidazole in asymptomatic women has not been shown to decrease rates of preterm labor despite eliminating the organism from its host. The next question reads, how should SGR be treated? All symptomatic women should be treated with metronidazole 2 grams orally as a single dose. Metronidazole is classified as pregnancy category B. Tinidazole 2 grams orally as a single dose could be suggested as an alternative regimen, however, it is classified as pregnancy category C. The next question reads, BJP, a 28-year-old, sexually active man, complains of painful penile lesions and tender inguinal adenopathy. The lesions are vesicular and limited to the scrotum, glands, and shaft of the penis. The onset of the lesions was preceded by a 1-week period of fever, malaise, headache, and itching. Viral culture of the lesions was positive for HSV infection. Describe the typical course and clinical presentation of herpes genitalis in men and women. What subjective and objective clinical data in BJP are compatible with herpes genitalis? Most initial episodes of genital herpes, especially in the male, are symptomatic. As illustrated by BJP, the symptoms usually start about 1 week after the initial exposure with prodromal signs of tingling, itching, paresthesia, or genital burning. The prodromal stage, which can last from a few hours to several days, is followed by the appearance of numerous vesicles. The vesicles eventually erupt, resulting in painful genital ulcers. The pain and edema associated with genital herpetic lesions, especially if they are infected secondarily, can be severe enough to result in dysuria and urinary retention. Bilaterally distributed lesions of the external genitalia are characteristic. The lesions usually are limited to the glans, corona prepuce, and shaft of the penis in males and to the vulva and vagina in females. However, lesions can occur on the buttocks, thighs, and urethra. Asymptomatic or mucopurulent cervicitis occurs in about 15% to 20% of women with primary HSV2 infections. Rectal and perianal HSV2 infections are more common in MSM and immunocompromised individuals. Symptoms include anorectal pain and discharge, tenesmus, and constipation. Prior infection with HSV1 may ameliorate the severity of the first episode of genital herpes, but it does not impact the rate of recurrence. In primary infections, the local symptoms of pain, itching, and urethral or vaginal discharge last from 11 to 14 days, with a complete disappearance of lesions in 3 to 6 weeks. Most patients have minor symptoms, are asymptomatic and unaware of the disease. They are most infectious within the first year of acquisition of the virus. The next question reads, is BJP's infection likely to recur? Most first-episode HSV2 symptomatic patients experience a recurrence of their initial infection. The rate of recurrent infections varies among individual patients. Approximately 38% experience at least 6 episodes, and 20% have more than 10 recurrences. Natural infection with HSV2 induces type-specific immunity against exogenous reinfection, but it does not affect recurrences. The severity of the primary episode and recurrence appear to be influenced by the host's immune status, especially a depressed T-cell response. Recurrent infections usually appear at or near the site of the initial infection, and prodromal symptoms are reported by about 50% of persons with recurrent infection. Men recur more frequently than women. In contrast with primary infections, there are fewer lesions and they are often unilateral. Constitutional symptoms such as lymphadenopathy, fever, and malaise generally are also milder. Recurrent infections are shorter in duration, average 1 week. Local symptoms such as pain and itching last 4 to 5 days and the lesions themselves last 7 to 10 days. Although there is wide variability, patients may have 4 to 5 recurrences during the first year, but reactivation frequency can decline by 3 reactivations per year during the first 2 years. By about 5 years after the initial infection, recurrence rates decrease greatly. Genital infections with HSV1, however, recur infrequently and decrease by 50% between 1 and 2 years after infection. The next question reads, BJP states that this is the first time he has had such lesions and that he has had only one sexual partner for the last 14 months. His sexually active female partner has no history of herpes genitalis or any other STD. The couple is very curious as to how BJP acquired his infection. How is HSV transmitted? Transmission of HSV occurs by direct contact with active lesions or from a symptomatic or asymptomatic person shedding virus at a peripheral site, mucosal surface, or secretion. Genital HSV2 infections usually are acquired through sexual, that is vaginal or anorectal, intercourse, whereas genital HSV1 infections are acquired through orogenital sexual practices. Because HSV is inactivated readily by drying and exposure to room temperature, aerosol and fomite spread are unusual means of transmission. Condoms may act as an effective barrier to viral transmission in women, but this method does not offer complete protection for men, as women often have perigenital lesions. Evidence suggests that the frequency of correct condom use is directly proportional to protection against acquisition of HSV2, and that condoms are more likely to be worn when lesions are present. A patient with genital herpes is contagious only when shedding the virus. The patient begins to shed virus during the prodromal phase, which may be several hours to days before the actual lesions first appear. Patients can, however, be asymptomatically diagnosed by serology and subsequently develop clinical lesions, or be symptomatic on diagnosis and have recurrent episodes of clinical lesions. Symptomatic viral shedding occurs twice as often than in asymptomatic HSV2 seropositive individuals, but subclinical viral shedding, i.e., no lesions present, still occurs approximately 10% of days, regardless of gender. From a public health standpoint, unrecognized subclinical shedding may indicate a greater need for serologic testing to reduce transmission. Lesions are most contagious during the ulcerative phase. The median duration of viral shedding as defined from onset to the last positive culture is about 12 days. The mean time from the onset of vesicles to the appearance of the crust stage, approximately 10.5 days, correlates well with the duration of viral shedding. However, there is considerable overlap between the duration of viral shedding and the duration of crusting. Women require a longer healing time than men, 19.5 and 16.5 days, respectively. The mean duration of viral shedding from the cervix is 11.4 days. Therefore, patients should be advised to refrain from sexual activity until the lesions have completely healed. However, subclinical viral shedding may also transmit HSV2. A genital herpes infection may be acquired from an individual who has never had symptomatic genital lesions. States of asymptomatic or subclinical viral shedding occur in the majority of women with recurrent genital herpes as a result of reactivation of latent infection. These recurrent infections can have a primary disease presentation, causing the patient to blame the most proximate sexual partner when in actuality the exposure could have occurred in the distant past. Serologic and virologic typing can be used to determine whether this is a true primary infection. Using sensitive detection techniques, such as PCR, women with recurrent HSV infections shed virus up to 28% of the time, but the relationship between a PCR-positive HSV test and true communicability has yet to be determined. In addition, asymptomatic spread can occur from multiple anatomic genital sites and in a bilateral fashion, even with previous outbreaks of unilateral lesions. Seropositive HSV patients also should be counseled to practice safer sex, using male or female condoms, at all times, not just during symptomatic episodes. The next question reads, viral culture was negative for BJP, but HSV2 point of care serology was positive for both BJP and his sexual partner. How should these laboratory tests to be interpreted? The accuracy with which herpes genitalis can be diagnosed without the aid of laboratory tests generally is difficult to achieve, especially if the infection is not symptomatic. Thus, because of the potentially severe psychologic and physiologic ramifications of such a diagnosis, either virologic and/or serologic confirmation of the diagnosis may be obtained. The laboratory diagnosis of HSV1 or HSV2 infection depends on isolation of virus using viral culture, while HSV DNA detection by PCR is more expensive than viral culture and not as widely available, or HSV antigen detection using enzyme immunoassay or direct fluorescent antibody. Both PCR and enzyme immunoassay can differentiate HSV1 from HSV2. Currently, HSV-DNA-PCR is the most sensitive method for detecting mucocutaneous herpes simplex infection rather than simple viral culture in those with genital ulcers and is the preferred method for CSF samples. Tests that measure serologic response, antibody production, are valuable in documenting primary infection, but they are not very useful in recurrent infections or to determine when the initial infection occurred. It is possible to differentiate between antibodies to HSV1 and HSV2 by means of type-specific serologic assay. Point-of-care devices using HSV2 specific antibody testing kits offer ease, reduced time, differentiation between HSV1 and HSV2, and high sensitivities and specificities. Viral culture is more likely to yield false negative results than other testing methods. A better antigen detection test could have been used, such as an enzyme immunoassay or direct fluorescent antibody. The lack of a positive viral culture does not rule out the diagnosis of a primary infection in BJP, especially because the antibody test was positive. The fact that BJP's partner's antibody test was positive without a history of symptomatic disease suggests a distant infection with asymptomatic shedding. The next question reads, how should BJP's lesions be managed? Because the likelihood of recurrence of genital herpes is high, what treatment and prevention measures are recommended currently? A diagnosis of genital herpes is concerning because there is no cure for the condition. Therapies ranging from antiviral agents and photo-inactivation to investigational vaccines have been tried. Currently, only acyclovir, famciclovir, and valacyclovir are useful in the treatment and prevention of genital herpes. The ideal anti-HSV agent should a. prevent infection, b. shorten the clinical course, c. prevent the development of latency, d. prevent recurrence in patients with established latency, e. decrease transmission of disease, and f. eradicate established latent infection. To date, no agent has been successful in achieving all of these goals. All three agents, acyclovir, famciclovir, and valacyclovir, are effective for the short-term treatment of some HSV infections. Acyclovir, a nucleoside analog, is a substrate for HSV-specific thymidine kinase. Through a series of phosphorylation steps, acyclovir is transformed to acyclovir triphosphate, a competitive inhibitor of viral DNA polymerase. Acyclovir has potent in vitro activity against both HSV1 and HSV2 and is far less active against varicella zoster and CMV. Famciclovir, a prodrug of penciclovir, has increased oral bioavailability compared with acyclovir. Once converted in the intestine and liver to the active form, penciclovir, it is quickly phosphorylated in HSV in a similar manner as acyclovir. Valacyclovir is the L-valyl ester prodrug of acyclovir. The oral bioavailability of valacyclovir is also significantly better than acyclovir, producing plasma levels of acyclovir comparable to those attained with IV-administered acyclovir, often eliminating the need for parenteral therapy. All three antiviral drugs are equally effective for genital herpes infections. Intravenous acyclovir dosed at 5 mg per kilogram, dose every 8 hours, significantly reduced the duration of viral shedding in primary genital herpes, decreasing the duration of signs and symptoms of disease by a mean of 5 days, and the time to healing of lesions by a mean of 6 to 12 days compared with placebo-treated patients. Similar findings have been shown in the immunocompromised patient population. IV and oral acyclovir or valacyclovir also prevent HSV reactivation in seropositive immunocompromised patients who are undergoing bone marrow transplantation. For patients with HIV, acyclovir 400 mg orally 3 times daily, famciclovir 500 mg twice daily, or valacyclovir 500 mg twice daily for 5 to 10 days have been used for recurrent episodes. Currently, IV therapy is recommended only for patients with severe genital or disseminated infections who cannot take oral medication. Topical therapy with acyclovir ointment, 5% in polyethylene glycol, has minimal effect on the duration of viral shedding, symptoms, and lesion healing in first episode primary genital herpes, and it has no effect on the recurrence rate and is not recommended for primary genital herpes. Penciclovir 1% cream applied every 2 hours while awake is effective for treatment of herpes simplex labialis, but insufficient data exists to recommend its use for genital herpes infections. Oral antivirals speed the healing and resolution of symptoms of first and recurrent episodes of genital HSV-2 infections. Treatment of primary infection after the first week of infection does change the natural history of recurrent outbreaks, thus, patients should be educated about risk of sexual transmission and prompt recognition of signs and symptoms and the early use of antivirals. The frequency of recurrence decreases with time in most patients. Recurrent episodes of genital HSV-2 infection can be treated with any of the 3 available oral antivirals. Rather than having to go into clinic, patients with recurrent infection should have a supply of their antiviral drug with them to allow early initiation of therapy, which may abort or reduce symptoms by 1 to 2 days. Daily suppressive therapy with acyclovir, famciclovir, or valacyclovir reduces the frequency of recurrent episodes up to 70% to 80% among patients with frequent, that is 5 to 8 episodes per year, genital herpes. Recurrent outbreaks diminish with time, thus, after each year of continuous suppressive therapy, an effort should be made to discuss discontinuing therapy with the patient. The use of suppressive therapy does not completely eliminate viral transmission. However, a randomized, controlled clinical trial of serodiscordant HSV-2 positive couples demonstrated a statistically significant decrease in the rate of transmission to uninfected partners when infected partners took 500 mg per day of valacyclovir. This 8-month study was restricted to heterosexual partners with fewer than 10 recurrences per year. The CDC recommends various dosing regimens for valacyclovir, but the 500 mg once daily dose appears to be less effective than the 1 gram once daily dose in patients with frequent recurrent episodes, i.e., more than 10 episodes per year. However, one meta-analysis showed a consistent prophylactic benefit if valacyclovir was dosed at 250 mg twice daily or 500 mg once daily. Immunocompromised patients may require higher doses or more frequent intervals for suppression. Most cases of acyclovir-resistant HSV occurs in the immunocompromised host, however, the resistance is less than 5%. All acyclovir-resistant strains are also resistant to valacyclovir, and most are resistant to famciclovir as well. Foscarnet 40 to 80 mg per kilogram IV every 8 hours or cidofovir 5 mg per kilogram once weekly until clinical resolution may be used for severe acyclovir-resistant genital HSV infections. Cidofovir 1% gel, not commercially available in the United States but has been compounded by pharmacists, applied once daily for 5 days may be an alternative to IV Foscarnet, but more studies are needed. BJP is not yet a candidate for daily suppressive acyclovir therapy. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 260.